Hi, everybody. I'm Michael Carrese, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Today, we add another voice to our ongoing conversation about how to improve the nurse staffing crisis faced by the U.S. healthcare system. That voice belongs to Bhavdeep Singh, founder and CEO of Global MedTeam. That's a startup focused on bringing foreign-born nurses to the U.S. to fill staff shortages. Mr. Singh is an accomplished international executive with a strong background in retail, healthcare, logistics, and HR, leading private and public companies on 3 continents, including Fortis Healthcare, which is one of the largest providers of healthcare in Asia. He's also the founder of WHA Partners and White Hawk Associates, an advisory platform launched in 2021 serving clients in retail, supply chain, and healthcare. When we first spoke to him 3 years ago, he was CEO of Health Quarters, which was partnering with the Mount Sinai Health System on an innovative delivery model focused on wellness. So welcome back to Raise the Line, Bhavdeep. I'm glad you could join us again.
Thank you very much. It's good to be here. It was only about 2 or 3 years ago that I was here, but quite honestly, based on everything that's happening around us, it feels like it was a long time ago. But glad to be here. Thank you. I appreciate the opportunity to be able to share a little bit about what's happening in our side of the world.
Absolutely. We're looking forward to it. So for those who did not happen to hear the show 3 years ago, let's start by having you tell us a bit about your background and what led you to get started in retail.
Well, I was like most, teenage kids, high school kids, trying to figure out what to do in life. And I grew up in White Plains, New York. And, this is in the, early 80s, quite honestly, when, as a minority, where diversity wasn't yet in term yet. So a young man with a turban on his head looking for a job. The red carpet was certainly not being rolled out. In fact, no carpet at all. And so, the question sounds like such a provocative one. What got me started in retail? Well, that was the guy that hired me. I would have started anywhere. And so I walked into a grocery store. There was a sign outside that said help wanted. I went in and I was nervous. And the store manager asked me 3 questions. How old was I? Could I speak English? And when can I start? And I got it was a fantastic interview. I apparently did well because 40 seconds later I was hired. And I started working, quite honestly, like most people. I mean, there aren't too many teenagers walking around saying, when I grow up, I'm going to be a grocery store manager. But I started working there, and my mother was horrified that her son was going to work in a grocery store. And I assured my mother, no, this was just temporary. It would be just a few weeks and maybe a couple of months, and then I'd get a real job. Well, I ended up staying with the company, and quite honestly, hard work, lots of good mentors, and a whole lot of luck and the grace of God. Eventually, I became president of the company.
Wow.
And so I started sweeping floors, stocking shelves. And, as I said, some 20 odd years later, I became president and had the good fortune of, being able to learn along the way. As I said, many, many good mentors, people who believed in me more than I did, gave me the opportunity to do something different and came up through the system, continue to work hard, learn, and did eventually become president.
Boy, there's a ton of lessons to learn on that kind of journey. And as I was mentioning in the intro, you went on to run a very large healthcare system in Asia. What was the jump from retail to healthcare for you about?
Well, as I mentioned, I became president of the company, and around the mid 2000s, I was born in India. Quite honestly, I lived most of my life here in the U.S., so India was just as foreign to me as it would have been to you. It was just a remote land that I'd visited once, and I came back thinking, that was fine. Let's go back to work and let's get back to life here. But around the late 90s, early 2000s, things started to change, and there was a big buzz in the market around BRIC. Everybody was talking about BRIC, right? Brazil, Russia, India, China, and the fact that these countries had a promising future. And I thought to myself, good Lord, for once in my life, it's good to be from India, because till then it really hadn't been much of an asset. Again, we were still an evolving nation in terms of understanding other cultures, understanding other people, how people live their lives, and really being able to develop and respect and insight in terms of what other people live their lives. So at that point, as India started to evolve, as India started to grow, as India started to change, I became very curious. What would it be like? what would it be like to work somewhere else? What would it be like to work in India? And I started waking up early every morning and started reading Indian newspapers to find out what was happening in India. And I had this urge to go to India. And, my family actually made fun of me. They said, what are you going to do in India? You don't know how to do anything. The Indian ecosystem and the professional environment in India is all academic based. Hundreds of millions of people walking around with MBAs, some of them working menial secretarial jobs, but everybody has an MBA. Everybody has, so many people have PhDs and doctorates, and here I am with an undergrad degree running a grocery store. It was, so what do I do in India? And I said, well, I'll have to figure something out, but I'm going. I want to be in India. And fortunately for me, right around the same time, organized retail started to take a hold in India. And that was new because till then everything was a independent grocer, independent corner stores, kind of like what we're used to, the nickel dime kind of store in the US, small stores like that. But organized retail started to take hold. So in 2006, with my family, I sold my house, put everything in a container, and moved to India. And I had the fortune of working with Reliance Retail. Reliance Retail is one of the largest companies in the world. When I joined Reliance Retail, we were just getting started, and just the ownership and the leadership at Reliance, just tremendous vision, tremendous appetite for growth, and being able to invest in that kind of a plan. We opened 700 brand new stores in less than 2 years.
Wow.
And at the end of 3 years, I was running 1,000 stores for Reliance Retail, which is very quickly became one of the largest retailers in the world. The only challenge for me then was that I was working in retail. Things were good. I'd been promoted a few times over and was running most of the business now. The challenge became that when I'd moved to India, I'd convinced my family that, oh, it's going to be great. We're going to go to India and we're going to spend time together. We're going to have quality time. We're going to, we're going to walk the streets. We're going to go to the markets. We're going to go to the temples. And the reality was I was leaving every Monday morning at 6 a.m. On a flight to Mumbai and coming back on a Friday night. And so I think the family challenges became quite significant. And I started thinking about, how do I come back to Delhi, Gurgaon, which is where my family was living. And right around the same time, I got a call one day from a recruiter asking me about a healthcare opportunity. And I hung up on the recruiter. I told him, I said, you got the wrong thing. Singing in India is, a bit like Jones in New York. I said, you got the wrong thing. I said, I sell rice and beans for a living. And the recruiter said, no, hold on. The board is looking for somebody who understands brand, who understands customer experience, who understands process. And I actually didn't know a thing about healthcare. What I didn't realize was that the company was talking to me, Fortis Healthcare, was one of the largest private healthcare providers in the world. And they were insistent that, we want somebody who understands scale, who can help us build this brand. And so after about 4 or 5 months, I became the CEO of Fortis Healthcare. And it was quite interesting when I joined Fortis Healthcare. At that time, the company had about 3,000 beds, which still makes it a very large health system, 25 hospitals. And I was completely clueless. I had no idea what was going on. Didn't know the difference between an OR and a cath lab, completely confused. And I just thought to myself, this is not going to go well.
Yeah.
But I worked hard. I started waking up every morning to start reading about healthcare, start reading about orthopedics, oncology, cardiology, starting educating myself. And I ran into a friend of mine right around that time, about a month or two after I was there. And he said, hey, I heard you joined Fortis. He said, how's it going? I said, it's terrible. I said, I have no idea what's going on. I'm so confused. I said, these guys, they're going to chuck me out of here. Well, give it a shot. What's the worst that could happen to you? But I did give it a shot. I kept working at it, kept reading, kept educating myself, read more and more about healthcare as time went on, and started spending a lot of time with doctors, with nurses, to really start building my understanding of what happens inside the four walls of a hospital. And about 3 or 4 months later, Michael, I ran into the same friend again. And he said, how's it going? How things with the new job? And I said, there are better things. They're actually getting. And he said, well, that's great. He says, so you understand healthcare now? And I told him, I said, no, but I'm not sure if anybody else does either. And my understanding and my learning at the time had been, and this happens in so many healthcare. It wasn't just Fortis; it was just everywhere. I mean, I've seen this in the US as well. Is that when we talk about healthcare, we make it sound like a commodity. We make it sound like a widget that we're selling widgets. The reality is that when a patient goes to see a doctor, when a patient comes inside a hospital, at that point, in a really fragile position, it doesn't matter who you are. It doesn't matter how big you are. It doesn't matter how much money you have. It doesn't matter what stature you have. When you don't feel well, when you go to see a doctor, that's you and I at our most delicate moment, right? We're actually concerned. And so the idea of healthcare and commodity was just so foreign to me. And I started talking to doctors about what does good patient care look like? How much time do you spend with a patient? And I had the good doctors educated me on how they handled it. And I ended up staying at Fortis for about 2 years. It was a great experience. Spent a lot of time with doctors, nurses, and a family tragedy unfortunately brought me back to the US. At that point, I spent 4 or 5 more years in retail. I ran Ahold USA. I was the head of US operations for Ahold, which is a $26 billion retailer, about 800 stores and 100,000 employees. I ran that for about 5 years. And then healthcare came knocking at my door again. Fortis reached out again saying, look, you always said you'd come back one day. We'd love to have you come back. And so I went back to India. I ran Fortis again for 4 years between 2015 and 2019. And then again, I had some family issues. The organization had gone through a transition as well. So I thought it was a good time for a change. I came back to the US. And more recently, I launched a startup with Redesign Venture Studio, launched a partnership with Mount Sinai. We launched a aggregate healthcare platform where we brought wellness and clinical under one roof. And that was just a great learning experience as well, because that helped me understand just the way people think about healthcare. And anybody who has, if somebody has knee pain or if they have a stomach issue, they're not just going to the primary care doctor. They're going to the primary care doctor. If it's a stomach issue, they're going to go see a nutritionist. They may go see sort of a doctor who's done some expert work. I've heard about people with stomach disorders who go to chiropractors.
Yeah.
If you have a knee problem, you're going to go to an orthopedist. You're going to go to a chiropractor. You might go to an acupuncturist. And so the idea, what we built at headquarters with Mount Sinai was we brought all of healthcare under one roof. And it was an aggregate healthcare platform where Mount Sinai brought in primary care and a series of clinical disciplines. And in the same building, we also had, dental, orthodontal, chiropractor, mental health. The idea being that give a patient the opportunity to get everything they might want in healthcare under one roof. So that was a great experience. And then more recently, last 2 3 years, started focusing on consulting. And what I'm really excited to talk about, what we've been working on here in the US now, has been really starting to look at the challenges that US healthcare is having with medical staffing.
Right, which is the bulk of our conversation today. And as I said, we've been talking to other folks about this, and we're really interested to get your perspective, partly because of that broad sweep of experience that you just talked about, but also that you do have a global perspective on healthcare. Most of the folks we talk about have only worked in the U.S., and so that obviously limits what they bring to the table. So I guess probably a good place to start is just to get your take on what's happening with nurse staffing, and then what Global MedTeam, how you guys are approaching it, what you're bringing to the space.
The journey on healthcare staffing started for me with a conversation that I had with a senior healthcare executive at a very, very large New Jersey health system. And I was just having a conversation about, what are some of the key initiatives they're working on, and, some of the things as a consultant, some of the things that I was working on. And, I was talking about the usual things, revenue cycle management. I was talking about, process improvement, patient experience, et cetera. And this executive turned to me and said, look, you really want to help me, go get me some nurses. I said, okay, I'll bite. Tell me, what does that mean? I asked him a question. I said, how big is your problem? And he asked me a question. He said, what do you think is my annualized cost for one travel nurse, right, over the course of a year? I said, okay, one nurse over the course of a year. And I just kind of played it out in my head. I thought to myself, typical RN on the East Coast, Northeast, 85, 90,000 salary. I thought about, what does a nurse practitioner make? What does a PA make? What does a nursing assistant? So I just kind of thought in my head, and so I asked him, I said, 130, 140,000. He said higher.
Yeah.
70, 180. I'm thinking now I'm at the top of he told me that his travel annualized cost for one travel nurse was over $350,000.
Oh my gosh.
$350,000. And I actually thought to myself, I said, okay, we're just having a conversation. So he's being, perhaps he's being a bit dramatic, and maybe he's rounding up in a big way. A month or two later, I was talking with an executive from a health system in New York City, the chief medical officer of a health system in New York City, and had the same conversation. And he just casually said, I said, this is the number I heard. I said, is that possible? I said, could it actually be that high? And this individual turned to me and said, no, that number is not right. He said, it's actually higher. it's probably 450,000 for us in New York City,
Good.
just because the cost of living is more, rentals are more, transportation is more. And I was stunned. I was thinking to myself, how is it possible that for an otherwise um, fully funded role, in other words, with benefits, vacation, if you put everything in, it's probably cost is probably about 110,000 at best. How is it that 110,000 replacement in any scenario is 3x that much, maybe 4x?
Yeah. Yeah, and we should point out that money's not going in the nurse's pocket. A lot of that difference.
Absolutely right. I mean, you have between the actual cost to get a nurse there, number one. Number two, the related costs of travel, et cetera, whatever it might be. But then there's a premium that's paid to the nurse, and then there's the agency. The agency who's actually, providing that service. And so you're right. The nurse, he or she may have, instead of making 95, 100,000, might be making 130, 140, maybe 150, but they're not making $300,000, obviously. But I was stunned. I heard the number and I was stunned. I was just flabbergasted. And so though I started looking into the space, I started thinking about, okay, just what exactly because I thought to myself, I've been a CEO, I've run companies before. And when you think about the nurse, which is a lion's share of your workforce in any health system, the nurses and the patient attendants are the ones who make up the lion's share of the workforce. How can anybody possibly afford to pay that? And that's when I started to realize that, the US today is short of 500,000 nurses. Now, you can look at different sources, and I've seen numbers as high as 600,000-700,000. I've seen numbers as low as 380,000-400,000, but it's not 10,000, right? We're several 100,000 nurses short. The other thing that's interesting is that the number of nurses that left the workforce after COVID, the number of nurses that are licensed nurses, but they're not working as nurses today, right? That number is also several 100,000 because they've just said that's not the life they want to live. And the worst, even the more scary part is the number of nurses that are planning on leaving. Again, depending on what data you look at, over the next 3 to 5 years, there's potentially another 3, 4, 500,000 nurses that are going to be leaving. Now you combine that with the fact that the demand for nurses is going up, right? And the reasons being obvious, the most obvious being that we have an aging population. You have the larger and larger Alzheimer's population, for example, full assist time kind of patient. And so the demand is going up, the supply is actually going down. And so, no matter how you look at it, our chief executive officer, Dennis Kogod, has actually said, that he says his line is, and I love the way he phrases this. He says, COVID was here for a while before we actually realized COVID was here. Everybody talks about March 2020 is when COVID started. COVID was here for a good 7-8 months before that. We just didn't recognize and acknowledge it. And the way he describes it is that, the second phase of the pandemic is here. It's the healthcare worker shortage, specifically the nursing shortage. It's here. We just don't realize how big a challenge it is. And, we believe that with these types of numbers, the number of nurses that are short, when you look at very often, you and I might go out to dinner with our family and they tell you, well, Mr. Singh, it's going to be an hour before we can seat you. And you say, well, you look around and you say, well, half the restaurant's empty. What do you mean it's going to be an hour? And then they tell you, well, we have no wait staff. And so those days where you go to a hospital, where you go to a doctor's office, and where doctor's office is cutting down hours, we've heard about doctor's office who have decided to run 4 days a week instead of 5 because they don't have the staff. They just take the nurses they have, run them 4 days or 10 hours a day instead of 5 days, 8 hours a day. Or if you have ICU, CCU areas that can't be fully staffed, so it's frightening. It's frightening, and so we've thought about. We did a full detailed inventory on what kind of solutions are being implemented. And there's some wonderful work being done in the space. Whether it's process improvement, whether it's optimization from a staffing perspective, scheduling to software to make sure that we have the right kind of scheduling. We've looked at remote monitoring as a time saver, and certainly instead of somebody having to go take your temperature, it's remote monitoring and it's done automatically. So all these things are very helpful. But let's just go with the number 500,000. Instead of needing 500,000, perhaps we need 450,000. Maybe we need 400,000. The problem is that the numbers are indicative of a problem that's getting worse. And so everything that we're doing today, certainly it helps. Certainly, technology helps. I read an article 2 weeks ago about NVIDIA, the software, talking about AI would produce technology that would be equivalent to a nurse at a $9 an hour rate.
What parts of a nurse's job are they talking about, though?
Remote monitoring, being able to do a diagnosis. But you can put technology behind all of it. But I tell this story very often. When I was running Fortis Healthcare, I got a letter from a patient one day. And this individual said, how thrilled they were. And 3/4 of the letter talked about the nurse and the wonderful care the nurse gave. And of that 3/4 of the letter talked about the nurse, most of it was about the fact that the nurse came in every day, 2, 3 times a day, whenever it looked like, the patient wasn't feeling great, and would offer to play gin rummy with them.
Yeah.
And I thought to myself, we don't teach our nurses to play gin rummy with the patients. In fact, not their job. We don't tell a nurse that if you see a patient who looks stressed, hold their hand, just hold their hand and sit, sing a song. I don't think we found technology that can do that yet. We all know, because that whole notion of when we go to see a doctor, when we go to a hospital, as I mentioned earlier, that's about as vulnerable as we can be. Right? That's when we feel, and I've said this before, that when you have a headache, when you have a really bad headache, and it's 3 o'clock in the afternoon, and we can't function because it's such a bad headache, that headache, my headache, your headache, is the biggest problem in the world.
Right.
Global peace comes a distant second, right? Because that's all you can think about. So having a nurse who can help you, who can make you feel better, who can give you some comfort, we're decades away, maybe centuries away from figuring out technology that's going to be able to do that. So it's a start. So we started scoping out and thinking about what are the solutions that are available, because we have such a big problem. And that's where we came upon internationally educated nurses. And that's what GMT is about. GMT is building a platform where we're looking at countries outside the US, that we can bring nurses from these countries to the US. And our primary focus area till now has been the Philippines. And we're now looking at the Philippines. We're looking at Mexico. We're looking at the whole LATAM region, where we think there's a big opportunity. And the Philippines has a very rich history with respect to nursing. I mean, the Philippines has been sending nurses to the United States since World War II. And some of the best nurses in the country that we have today are Filipino nurses. And if you talk to any doctor or any healthcare worker, even other nurses, they'll tell you that the Filipino nurses are the ones that are amongst the hardest working. They just do a fantastic job, and just are a huge value add. And we think there's a big opportunity. The Philippines, we visited the Philippines now 6, 7 times in the last year and a half. The ecosystem in the Philippines is built to send nurses to the U.S. A predominant number of nurses that become a nurse in the Philippines do so for one reason, which is to come to the United States. And the infrastructure is such. The English language in the Philippines is a very strong second language. Everybody speaks English. Children are taught to speak English in school there. And we think it's a huge opportunity. It's a huge market to bring nurses here. And so our focus is that.
I mean, that does beg the question, sorry to interrupt, about what happens to the folks back in the Philippines who need care. I mean, this idea of taking too many nurses away from any particular country or area.
Well, it's funny. I think that's a good point. And we looked at that point as well. And what we found was that there are approximately 1 million nurses in the Philippines today. Of the 1 million nurses, a little over a half are working in healthcare as nurses. 40 to 50% of them are working outside of healthcare, because a Filipino nurse makes about $500 to $600 a month. And if they work in a call center, they can make $800, $900 a month. If they work in a restaurant, they can make more money. So the nurses that are coming to the US, and by the way, so in a country with 1 million nurses, where 500,000, 600,000 are working as nurses, the US, taking 5, 10, 15,000 nurses is not material, number one. Number two, there's a compensation issue that they're working on fixing there in terms of getting that right. But so I think there are lots of nurses that are available in the Philippines. I think it's more an internal issue that they are working on it. I think the government's focused on it. The private healthcare employers are working on it. So I don't think that the number of nurses we might take, even if that number was 15, 20, 50,000, it's not going to materially impact what's happening there and their demand and their challenge. Because you're right, they do have a challenge, but the challenge is more driven by their comp structure versus GMT taking some nurses from there.
What do you do about the credentialing question? I mean, whatever the educational infrastructure is in the Philippines and what they consider to be a registered nurse versus what we would consider it to be here in the States? Is there any big difference there?
There are differences. There are differences. However, there's a couple of things that's happening. Number one, the ecosystem in the Philippines, the nursing ecosystem is very, very strong. And for a nurse to be a registered nurse, you have to pass the NCLEX examination.
Ah.
They have to pass the NCLEX, and then they have to be certified by state. Nursing, to get your nursing license, you're certified by state, like many professions in the US. The way the system is set up today in the Philippines is that a nurse can take and pass the NCLEX examination in the Philippines. The state certification can be done in the Philippines. Theoretically, a nurse could work on a Saturday night at a hospital in the Philippines, hop on a plane, land at JFK on a Sunday evening, and Monday morning start seeing patients at a New York hospital. So all registration, certification, everything is done in the Philippines. And when the nurse shows up here, they would have to certainly get onboarded, but just like any new employee would be in any company, everything from, what's the uniform, who's in charge, where are the bathrooms, what forms, what documentation do we use, but it's done completely there. The other thing that we're doing at GMT is that, in principle, we have a partnership with one of the largest health systems in the Philippines. And so we would actually, every nurse that we bring to the US, not only would have passed the NCLEX examination, not only would have English proficiency, not only would they be state certified, they would also go through a US nursing protocol training regimen. Our chief nursing officer, Michael Moorhead, has developed a full training program. And so every nurse that GMT Global MedTeam would bring over would actually have gone through, again, A, NCLEX examination, B, English certification, C, state. In addition, a Global MedTeam certified US nursing protocol program, confirming that exactly the theoretical example I gave you, where they could actually leave here on a Saturday, Monday morning start seeing patients in the US to enable them to do that. So we think the gap is not significant. And one of the things that helps, quite honestly, is that the loyalty and the dedication of Filipino nurses. I'll share a statistic with you, which is quite humbling. During COVID, we all know that, obviously, very sadly and unfortunately, many healthcare workers even got COVID, and some of them passed away. The Filipino nursing fraternity makes up for something less than 10% of all the nurses in the USA today. Right? So if you take all the Filipino nurses in the US, they make up for less than 10%. However, almost 1/3 of all the nursing deaths in the US as a result of COVID were Filipino nurses.
Oh, my goodness. That is very surprising. Yeah.
That's a function of the fact that these were the nurses who signed up for the late night shifts. They were the ones who signed up for ICU. They were the nurses who signed up for trauma, urgent care, where some of the highest infection incidents were. And so that statistic, every once in a while you hear something that you say, okay, I don't think I'm ever going to forget this data point. Well, that's one of those data points that I don't think I'm ever going to forget, that making up less than 10% of the nurses in the country, yet 1/3 of all the deaths in the country. And that's a function of their dedication, it's a function of their commitment, and the fact that they do what it takes. And by the way, we have great nurses in this country, so that's not to take away from any nurse.
Sure.
It's just a function of the fact that these nurses are, I think on most level just as good as anybody else. And I think they can be a big help. I think that's, every time we think about what's happening in nursing, we ask ourselves, what's the best way to think about it? And the reality is, we can try all sorts of solutions. We can try all sorts of things and say, will this work? Will that work? And we should. And every one of them, whether it's a process improvement, whether it's infrastructure change, whether it's some technology, enhancement, whether it's some machine learning, we should do all of those things because we need all of them. But that's not going to get us to where we need to. We still have a huge shortage. And the worst thing about this is that it's actually getting worse. And I guess one last thing I would say about this, just specifically this topic, is that while we're talking about nurses, when you start talking about home health care workers, phlebotomists, nursing assistants, that number is about 1 million today. So nurses by itself is 500,000, 600,000. But in addition to that, we have 1 million other healthcare workers that we're short right now. God forbid we have anything that even remotely resembles COVID, even a bad flu season.
Yeah, we're really not prepared in a lot of ways.
We're not prepared, and we're merely saying our view at Global MedTeam is that that we've put together a process where we've made it turnkey. We handle everything for a client. From the time that they say, okay, get us 20 nurses, we get the client 40, 50 nurses to interview. They pick the 20 they want. We train those 20. We handle everything on immigration from start to finish. From start to finish, we handle everything. And we've made it as easy, as simple as possible. And so, we're working with one of the top immigration law firms in the country. So our approach is don't make it difficult, don't make it hard, don't make it challenging, where people say this is too confusing. I can't, I have enough to do. Tell us what you need and we'll take care of the rest. And that's why we think this is a real viable solution and something that, quite honestly, I think we need to have in this country.
So I don't have a sense of how long you've been working on this. I'm just curious how it's going. What kind of reception are you getting? What kind of traction are you getting? What kind of questions are you getting from the healthcare systems that you're trying to work with?
We formed about 8-9 months ago. It took us this long to get our processes right. We have an office in the Philippines now. With a team in the Philippines, we have an office here. We're setting up an office in Mexico as well. So we're the infrastructure piece, getting our processes. You heard me reference a training program, U.S. nursing protocol training program. So developing all of those things. We've written a white paper on the state of nursing in the Philippines. Not too many startups are writing white papers, but we thought we needed to do that to educate people in terms of what's happening. We've written a white paper on the state of nursing in the U.S. and what's happening there as well. Again, because we think we have to educate people and to help them understand what's happening. So with that said, we're just starting now to engage with clients. We've just received our first 2-3 orders, placement orders this week. And so we're excited about that, the fact that people are starting. I think the questions that are, so the first set of orders are coming in, placement orders are coming in. I think the questions people are asking, one of them is the question you asked earlier is, how do the Philippines feel about this? How does it impact their nursing, on-ground nursing situation? And, we thought that was a really good question, and that's why we researched it. That's why the data points I've shared with you is something that now is, that we happen to know quite well. There's a question on, people ask about the English language. Is there going to be any language barrier? We all of us call, whether it's Marriott Hotel or MasterCard or Amazon, we call these call centers all day long. Most of them, a good chunk of them are from the Philippines. And very often you can't tell, because the language proficiency is actually quite, they're actually very, very good at it. So I think those two things have come up quite a bit. And then the whole immigration piece has come up. And the immigration piece, we actually handle it from start to finish. So we see traction building now. We just attended the conference in Florida, which was about 3 weeks ago. We attended a rural Texas hospital summit last week. So the interest is building quite nicely. There are a lot of people who are interested. There's a significant need out there. And so we see this as becoming a significant enabler as we go forward in terms of nurses, and as we go forward, other healthcare workers as well.
And by that, you mean the allied health professions you were ticking off before?
Yeah, because I think that, very often, the problem is that when you don't have, whether it's a phlebotomist, when you don't have health aides, when you don't have nursing aides, what ends up happening is you actually further exacerbate the nursing shortage, because now nurses end up doing these things. So now you have nurses that are replacing bedpans, nurses that are cleaning up because you're short some other. So it's a bit of a vicious cycle. And so all of a sudden, a health system that might be short 20 nurses, but 40 other, healthcare, it feels like you're short 30 nurses because nurses are doing non-nursing duties because they have to. Somebody has to do it. So yes, we as I said, started with nursing, but we're very quickly pivoting and jumping and looking at other roles here because we think that is a big crying need. It's on page 3. The nursing headline, nursing shortage, is on page 1. So it's a little bit behind the scenes, but it's coming. It's going to be page 1 news very, very soon.
No, I agree. I mean, there's heard numbers just for the state of California of needing, I think it was 100,000 allied healthcare professionals, by 2030, or one of these numbers that just makes you wonder, how are we going to keep functioning as a healthcare system?
The reality is, as Dennis has said, we have a problem. We just don't know it yet. And so that's, GMT, that's why we brought GMT together. I'm very, very pleased with the team we have, the folks that are here, seasoned, mature healthcare professionals who run big businesses in healthcare, who understand healthcare. And we all have one thing in common. We all believe, and we're working day and night, that if we don't help solve this, This is going to be something that's going to impact every one of us and how we live our lives. And God forbid, if one of us gets sick, the challenges we're going to have in a health system that, quite honestly, is not going to be able to handle the kind of disease burden, the kind of incidents that take place, or, again, I keep saying this, God forbid we have another pandemic or anything that remotely looks like that, we're going to have a big problem. And so hence we're hopefully working to at least in some way, shape or form, mitigate that and help our health system do a better job.
Well, I would say you're not overstating the nature of the problem, that's for sure, based on what we hear from so many of our guests. And I would also say that the framework that it's going to take lots of different kinds of solutions to really get this into a manageable place is also true. So, we're happy to learn about the approach you're taking, and we wish you guys a lot of luck. Hope you can take a big bite out of the problem.
Thank you. Thank you very much. And we're under no illusion that this is, cure all. We think we can be a part of the solution. But, we all need to do a lot more as we go forward. So thank you for the opportunity and appreciate being able to share some of our thoughts with you.
We appreciate having you. Thanks very much for your time. And with that, I'm Michael Carrese. Thanks for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.